Hello, everyone. My name's Giselle Metta, and I'm the Executive Director of Operations at Metta Health. We know that people are busy at the moment, and so taking time out of your really busy schedules to be here, using your precious time, means a lot to us. But we think it will make it worth your while. Really happy to have Mr. Nigam here. We've got lots of people from all over the globe. We have people from the USA, from Canada. We have people from Dominica, Trinidad and Tobago, Oman, Iran. So we're really excited about that. Before we start, and before I pass you over to Mr. Nigam, who I have to say is an expert in his field. He's one of the best urological surgeons in the UK. And I know he'll introduce himself to you, but we're really, really fortunate to have him here with us. We're really thankful to the Focal Therapy Clinic, who are our partners for prostate cancer treatment here in the UK. Before I pass you on to Mr. Nigam, we'll just do a run through of the programme for today. We will have just an overview of prostate cancer treatments, the traditional treatments, and then an overview of HIFU treatment. We look at the role of precision imaging in HIFU treatment, and then Mr. Nigam will talk about what happens before and after. And then we'll have a question and answer session led by Mr. Nigam. Without further ado, we'll just hand over to Mr. Nigam and he'll introduce himself to you. Thank you again.
Thank you very much. So firstly, thank you very much to Metta Health for arranging this webinar. I'm very, very pleased to be speaking to the participants today, and particularly from the African subcontinent. I will, through my presentation, highlight why this is important to me, and in particular, the treatment of African American and Afro-Caribbean men who have prostate cancer. It's something that I've podcasted on and blogged about for quite some time, and the reasons why these men deserve better care. I have to say I've treated a lot of men from the African subcontinent already, particularly following the pandemic, and particularly as modalities like Zoom and Microsoft Teams have become available. Most of my clinics nowadays have at least some overseas consultations within them, and largely relating to prostate cancer. So my remit is as per the agenda, and I will concentrate on just certain areas in prostate cancer, but I'm very happy to take questions about other aspects of prostate cancer that people may have pressing. There's been a lot of change in prostate cancer over the last 10 to 15 years, not just in localized disease, but also in advanced disease. And we're going to be concentrating on early localized disease because that is our greatest opportunity of achieving cure. So there have been paradigm shifts in how we diagnose. I will touch upon PSA screening, since that is what is readily available in most countries around the world, and why it still remains a little controversial as to whether we should be screening at all. I will then talk about multiparametric MRI and its role in diagnosing prostate cancer. We will also touch on the types of biopsies that we have available and the tools that we have to make things much more precise and much more exact. I won't go into detail about biomarkers. They're extremely expensive and not routinely used even in the UK. Advances in treatment we'll then talk about in localized disease, and in particular focal therapy. So just to remind ourselves of, how common is this horrible cancer that we have to deal with. It is now the commonest cancer in men. Second in deaths only to lung cancer, but that will soon be overtaken if it hasn't already in many countries. It forms 25% of all new male cancers, and it's generally a disease of men over 50, but we are diagnosing much more younger men. And 75% of cases are in men over the age of 65. The death rates have declined in most Western countries, and I'll allude to why that might be the case. The incidence, however, is increasing. We are diagnosing far more men, and as a result, more men are dying. But in terms of the rates, the mortality rates, they do appear to have declined. And I'll show a graph regarding this very shortly. So in the United States, the latest data that we have, there are about 224,000 new cases. So the overall prostate cancer population will run into millions. But the number of new cases was 224,000. And the number of deaths in that year were 31,000 in the US. In the UK, the latest data that we have suggests over 50,000 new cases and 12,000 deaths within the UK. So this slide looks at the mortality from prostate cancer, and it's a rate per 100,000 from the 1970s onwards. Okay, and what you'll see that it peaked in the early 90s, but it appears to have declined and leveled out in the sort of mid-40s. And the mortality rate is expected to go down further. Like I said, there have been advances not only in early diagnosis, but also in terms of in terms of the survival rates in advanced disease. More people die now from prostate cancer than they do from breast cancer, which used to be one of the greatest killers of cancer in the UK. So we can see a convergence about 5 or 6 years ago, and now the number of deaths from prostate cancer is above that of breast cancer in women. And the reason why this is important, that in the United Kingdom and in the United States, there are screening programs for breast cancer. So the question will then be asked, well, why aren't there screening programs for prostate cancer in men? A few more data. 12% of all male cancer deaths, 80% of men age 80 will all have a focus of prostate cancer. In the USA, it's estimated that 1 in 7 men will develop prostate cancer in their lifetime. And in the UK, it's 1 in 8. I'll come on to a breakdown of that in a moment. Increasing incidence, like I said, over the past 20 years, but a slight decline in mortality. High incidence, both in the UK and US, in men of African origin. So Afro-Caribbean men, those men in particular who are of African origin in the Caribbean, and also African American men have a much, much greater incidence of prostate cancer. Not only that, sadly, the mortality from prostate cancer is double that of white Caucasian men. So in the UK, the incidence is 1 in 4 versus 1 in 8 of white Caucasian men, but the mortality is also 1 in 4 for men of Afro-Caribbean origin. This represents a very major health inequality, and it's something that we're trying to address, but it will only get addressed if there's a massive cultural change. So paradoxically, in terms of screening programs, although the UK government does not sanction a screening program, the group that is most affected by not having screening is quite clearly Black men of Afro-Caribbean origin. There appears to be a greater preponderance in Northern Europeans versus Southern Europeans, so it's low in Mediterranean countries, and it appears to be low in Asians and in Chinese men until they decide to emigrate to the West. The only other factor that will govern your increased risk of prostate cancer is if you have a first-degree relative who has prostate cancer. So a father, a brother, or an uncle, you have a 2.5 to 3-fold increase in your chance of developing a prostate cancer. And if you have 2 relatives, the increase is much greater. And if you have a relative under the age of 60 who has developed prostate cancer, then there's an over 4-fold increase that you may well develop one yourself. So the so-called screening tool that we have, and that is ubiquitous, is a PSA, which stands for prostate specific antigen, which is a blood test. Like I said, widely available around the world. What does it actually do? It seems to have a role in your fertile life. So it helps liquefy the semen. But it is really a marker of prostate activity. It's not necessarily a marker of prostate cancer. So you can have an elevated prostate PSA level and not have prostate cancer, and you can have a normal PSA level and still have prostate cancer. And that's why it is a controversial tool in the screening program. We've had lots of headlines in the UK about the fact that routine prostate tests may do a man more harm than good. And that relates to overdiagnosis, over investigation, and perhaps over treatment. Having said that, there's been quite high media personalities such as Bill Turnbull, who sadly died this year, who was diagnosed 3 or 4 years ago. And he came out and said, if I had been tested earlier, then I would have discovered it before it had spread. So like I said, we have to deal with these sorts of headlines. But as I said earlier, one of the specific groups that are more disadvantaged by not being a screening program is men of Afro-Caribbean origin. Okay, so PSA, like I said earlier, can be elevated due to other reasons. A standard enlargement of the prostate due to BPH, benign prostate hypertrophy, will lead to a slightly increased PSA. Urinary tract infection, UTI, is also a very, very common cause. So we often ask our primary care people just to be absolutely sure that your PSA reading is not due to a urine infection. So we ask a urine test to be done, and if there's an infection, then the PSA should be repeated. Instrumentation, i.e. people like me poking around, looking down bladders and so on, that can lead to a PSA elevation. And of course, prostate cancer can lead to a PSA elevation. In the UK, we advise men to exclude a urinary tract infection, to have not ejaculated within 48 hours, as that can put it up, not to have exercised vigorously, particularly on a bicycle, in the previous 48 hours, and certainly not to have had any prostate biopsies in the previous 6 weeks. Digital rectal examination by a urologist or a primary care professional should be avoided a week before doing a PSA test. There are some PSA refinements to help us diagnose a bit better. We use PSA density quite a lot, and you can, if your laboratory will do it, do a free to total PSA ratio. It's important to recognize that increasing age does put up the PSA slightly. We use these sorts of broad categories. In your 50s, PSA of greater than 3 should warrant investigation, in your 60s greater than 4, and in your 70s greater than 5. That has been modified very recently to bring it down even further, but this is a good way of remembering it. In your 50s, over 3, in your 60s, over 4, and in your 70s, over 5. This was a trial that looked at screening. A lot of men involved, 189,000 men were asked to attend for screening. And there was a control group that did not have a PSA, more than 219,000 men, and a screened group that did. And they used the criteria of PSA greater than 3, and only men between 50 and 69 were invited. The incidence of prostate cancer was greater in the screened population, 4.3% versus 3.6%, but prostate cancer deaths were not statistically significant. What they found that there was a greater degree of low-grade, what's known as Gleason 6 prostate cancer. Hence, the conclusion was that the single PSA screening test did not affect mortality, but it did detect more low-risk prostate cancer cases. And therefore, they concluded in the Journal of American Medical Association that the findings did not support the single PSA test. And overnight in the United States, they stopped prostate cancer screening. 3 or 4 years later, headlines like this began to emerge, saying that if you didn't have a PSA test, more men presented with metastatic disease, i.e. disease that had already spread. So they downgraded their recommendation from absolutely refusing PSA testing, and they started selecting populations that could have screening, and one of those populations was African American men. So that's the PSA and a broad overview of where PSA lies. So it's obviously the starting point of our testing. We then come on to what I like to call precision diagnostics. And this really consists of precision imaging and precision biopsy, which are the next steps in the diagnostic pathway. By precision imaging, I mean a multiparametric MRI scan. I know because I receive those images, there are some excellent scanners in various parts of Africa. So MRI is available perhaps not in the public health system so readily, but certainly in the selected private health system, there are plenty of good MRI scanners in the African subcontinent. Also with precision imaging, we are talking about staging scans. And by staging, I mean assessing how far the disease has spread. The MRI will look at the pelvis, but the staging scans will look at you from top to toe. The standard criteria, particularly in our public system, is to do a bone scan, which is now considered not to be particularly sensitive, but we still do it, and or a CT scan. But the ideal, and a lot of us in the field are now moving towards this, is something called a PSMA PET CT scan. And that looks at you from top to toe, looks at the bones, looks at all the organs, and is very, very sensitive for detecting metastatic disease. And we are using it increasingly, although we are restricted in the public system to use it. But if you go to Australia, for example, every man who's got prostate cancer will have a PSMA PET CT scan. And I've also seen in Northern Africa, in Egypt, in Cairo, some of my patients are having what's called hybrid PET MRI scans. They've obviously got the machines. There aren't many of them in the UK. There's one at University College where I work, but and this is sort of the holy grail, whereby you can do one test which incorporates MRI and PET CT, and it will tell you A, whether you've got a cancer in the prostate, and B, if it has spread, all in one scan. I think its efficacy and so on and sensitivity needs to be looked at, but that is the sort of holy grail that we are hoping to achieve, that a man will just need one scan and it will give us all the answers. And then precision biopsy, I'll come on to as well. So you might think a biopsy, yep, straightforward, you just biopsy the prostate and that's it. But there are a number of choices out there. There's so-called template versus and mapping biopsies, which basically means that every 5 millimeters of the prostate, you stick a needle into and try and diagnose prostate cancer that way. We've moved away from that. There was a phase a few years ago when we used to do that for everybody, but we were discovering far more insignificant prostate cancer that wouldn't kill anybody. Then there is systematic versus targeted. By targeted, I mean knowing where it is from the MRI and just targeting those biopsy. Systematic means, going through both sides of the prostate and biopsying them. So you can do both of those. You can do targeted on its own. And then the route of biopsy is really important. Transperineal, which a lot of us are moving towards in the United Kingdom, versus transrectal, which was the traditional route, i.e. through the back passage. An ultrasound probe could be done under a local anesthetic, could be done by a nurse, and that was a standard way of diagnosing it. We've since shown in one of our studies that it is not very accurate and you can't reach certain parts of the gland. So most places in the UK have moved towards transperineal. Local anesthetic versus general anesthetic. Local anesthetic is the popular way of doing it because most hospitals don't have the number of beds available in order to admit everybody for a general anesthetic. In the private sector in the UK, we like to see our patients again and not have them swear at us. So we like to give them a general anesthetic so they don't feel anything. And then fusion biopsies, whereby we take the MRI and fuse it directly with the ultrasound, which I'll come into a bit more detail on, is something that we have adopted, and we've published on this and shown it to be a very accurate way. And we use software fusion. So those areas in red are basically what we offer for what we would call the gold standard of biopsies. And like I said, even throughout the UK, particularly in the public health system, we can't offer all of those things. So this is the ideal, to do a 3 Tesla, which is the strength of the magnet of the MRI scan, with gadolinium contrast. So we give contrast. Again, there is a vogue in the UK to try and shorten the scan and to reduce the cost. And so we do, some places are doing what's called biparametric, and it's being studied, which means without any contrast injection. But if you've got a 1.5 Tesla MRI scan and it's well protocoled and well configured, then you can get just as good data from a 1.5 Tesla. And I know, again, there are a lot of 1.5 Tesla scanners in Africa. But ideally, a 3 Tesla is great. And then, like I said, what we tend to do are transperineal fusion biopsies under general anesthetic. So there's been a shift in the pathway, which used to be get your PSA done, have a transrectal biopsy under local anesthetic, fire 12 shots up your backside. Hopefully you hit the prostate, hopefully you hit the right area. And if cancer comes back, you're not really sure exactly where in the prostate it came from. That's now changed completely to doing an MRI first. You do not do any biopsies without doing an MRI first. And those are the T2 weighting and differential weighted imaging and so on, are the multi-parameters that we look at in the MRI. These are some of the images that we see. I've chosen big obvious ones. Hopefully you can see those if they're projecting okay. So you can see that there's an area of concern on the left side of the prostate gland. The rectum is the black area underneath. And the other parameters are all showing that it all tallies, and the contrast imaging below suggests contrast is being taken up, i.e. it's got a blood supply, i.e. it's got a cancer in there. This is the trial that was published a few years ago, which basically said that forget transrectal ultrasound biopsies. MRI was far more sensitive, and that you must have an MRI before any type of biopsy. But the other advantage was that if there was no abnormality on the MRI, 25% of men could actually avoid biopsy. These are the sort of reports that are produced by our radiologists. I won't bore you, but the scoring at the bottom on the left is the high probability of there being a cancer or not. And it's a scale from 1 to 5. They actually rate all the areas in the prostate out of 5. And they highlight for us exactly where we should be pointing our biopsy needles. So these are the sort of precision imaging with precision reports that we get following a 3 Tesla multiparametric MRI. And then the types of biopsies, like I said, the transperineal route is done with the patient in the lithotomy position, legs up in the air. Women will be familiar with that from childbirth. And like I said, the accuracy is much greater because we use a grid and pass a single needle through the area of concern versus the old-fashioned transrectal biopsy, which, as you can imagine, had a high incidence of sepsis and infection, and particularly serious sepsis. That's just talking about the biopsies again. And the MRI ultrasound fusion is a relatively new technique. So we use the MRI that has been taken, and our radiologist contours the areas of concern. So they draw digitally on the screen any area of concern that they think might be cancerous. That is then loaded onto Clever software, and there are a number of different software programs, and brought down to me on the day that I'm doing surgery. So this is a scan where they've contoured 2 areas of concern. Now, I could choose just to biopsy those areas if I wanted to, thereby limiting the biopsies that need to be taken, thereby limiting any side effects that the man might get from taking multiple biopsies. And again, our studies have shown that with a good MRI scan and fusion biopsies, your chances of missing a clinically significant cancer is about 3%. So we often do targeted on its own, and that's just the process. So this is the actual live ultrasound image, and you can see the superimposition of the red area and the yellow area, whereby we know if we put our needle into that area, we will be targeting the area of concern on the MRI. You see, the ultrasound cannot see the same areas that the MRI sees. If that was the case, then we wouldn't need to do an MRI at all. So it's a combination MRI ultrasound fusion that we use to make the diagnostic biopsy. So that's the diagnostics that we are doing. Okay. We then come on to focal therapy, which by definition means just treating the area of the cancer and not the whole organ. So there are what we call whole gland treatments and focal treatments. The standard whole gland treatments that we have are radical prostatectomy to remove the whole prostate, which is a fairly big operation with quite a lot of side effects, or irradiating the whole gland with radiotherapy. And there was an interesting paper done on purely African American men on their experience in prostate cancer. And they found that a lot of African American men chose not to have anything done. They were diagnosed late, and they tended to choose radiotherapy over other treatments. And there are cultural reasons for that, patient perceptions and so on, which have all been studied as to why a man chooses a particular treatment. But what I found in my limited experience of men from the African subcontinent is that men will be very, very keen on preserving their erectile function, on preserving continence. You'd think that all men would be, but actually that's not always the case. And I can vividly remember a lovely African gentleman that I spoke to who basically said to me, "Mr. Nigam, you can do what you want to me, but don't touch my manhood." And that stays with me. And that is true of a lot of African men from the subcontinent, that they do not wish to have anything disturb those important functions. Now, interestingly, there is a little yellow area on the other side. And the reason why I've highlighted that is that the yellow area has been diagnosed as insignificant cancer. So that's what I mean by, watchful waiting or active surveillance, that the Gleason 6 or the low-grade prostate cancers can just be watched, and that's what we tend to do. So if the significant cancer, i.e. grade 7 or above, is on the other side, then that's the area that we would target. And how do we know this? We know that there was a beautiful study done a few years ago, 2009, which demonstrated that low-grade prostate cancer does not lead to metastatic disease, does not kill a man. Okay. In African American men, we have to be very careful with that statement, because African American men may have a higher grade disease which is about to develop, and they are much more likely to develop metastatic disease. So this is a very important study regarding low-grade disease that's saying basically it's a high-grade tumor that will metastasize, but we have to be a little bit careful in the population that we are treating. And this was another beautiful paper from University College, which looked at whether low-grade cancer was malignant or not, and whether and why you could watch the other things. And they came up with the concept of what's called the index lesion, which on that previous slide was that red area. Okay, so that is a lesion that's likely to spread and metastasize. So that is the one that we target. And our imaging and our biopsies have got so good now that we can distinguish index lesions from non-significant cancers. That's just some data showing that we do not need to treat low-grade disease. Big studies in the United States, 10,000 men and 14,000 men, which showed that. I'll move on from there. So what focal therapies are there? We're going to be concentrating on HIFU, but in fact, there are others. And, we do all of those. Well, we do the first three. Interstitial laser doesn't really have much data around it. But cryotherapy and irreversible electroporation, also known as nanoknife, are all other modalities. Cryotherapy, by definition, means freezing the area, getting down to temperatures of -80 in order to kill the cells. And irreversible electroporation is using electrodes with a high voltage between them, which causes holes in the cells, which will then die off. So less data on nanoknife than cryotherapy and HIFU, but it's something that we are looking at as well as an alternative. But HIFU is the one that there is greatest data on. It's obviously used only in the area of the tumor. This is one particular study, and I'll come on to others. This study is now about 10 years old. Initially, it showed very good preservation of sexual function and 100% continence, and 95% at 1 year. So this was one of the very first studies. We know that HIFU can be repeated if you have a recurrence, and it does not exclude future treatment options such as surgery or radiation if required. HIFU itself is ultrasound, and therefore there is no radiation involved. This is the company that we use, Sonoblates. It's a US-based company, but I was actually trained on the French device, Ablatherm, to begin with, and I now have switched to the Sonicare device, Sonoblate. So within the UK, we've had a big program on focal therapy. We started collecting data from 2012 when we achieved permission, if you like, to treat focally. And there's still some controversy surrounding whether to treat focally or not. And we did not treat low-risk disease. We only treated grade 7 or above. This was another earlier paper. I'll come on to the later papers, actually. It's probably better. So this is the heat registry data. Treatment is given through the rectum. And so this was, again, a paper that showed 3% urinary incontinence, which persisted at 3 years. So only 2% at 3 years. And erectile dysfunction rates were of the order of 15 or 16%. This was the sort of seminal paper that we published, our group, of 5-year outcomes following focal therapy using HIFU. 625 men were evaluated. Vast majority had intermediate or high-risk prostate cancer, and we showed that 99% had what's called failure-free survival, which basically means that they did not require any other treatments, they did not develop metastatic disease, and it was at 1 year was 99%, 3 years 92%, and 88% at 5 years. Overall survival, patient surviving was almost 100%, so nobody died during that period, and the cancer-specific survival rate was 98%. Only 2% of men had a degree of incontinence. This was updated just this year. Over 1,000 men, and some of these men were followed up for about 15 years now. And there was quite a lot of high-risk patients in this group now. We have started treating more high-risk patients selectively. And we found that 18% had to have a repeat focal treatment in a median follow-up of 7 years. And 92% had to have either a radical prostatectomy or radiation. So, and that was only 6%. So what that means is that 94% of men avoided having the basic treatment options which are offered. Okay, so that's quite a significant number who did not need to have radical prostatectomy or radiation. And you can redo focal HIFU. The beauty of ultrasound is that unlike radiation therapy, once you have radiation to one area of the body, you can never have radiation to that same area again. And the reason for that is that the radiation initially destroys all the tissues nearby. And so you run into lots of complications if you give radiation again. But with HIFU, you can redo it. If it comes back on the same side, you can redo it. If it comes back on the other side, you can redo it. This is another way of showing failure-free survival and metastasis-free survival. Now, I think that one of the items on the agenda was before and after HIFU. So what I thought I'd do is I'd give you a real patient profile that I presented at other meetings before, and that will illustrate, hopefully, the journey that this particular man took and what happened before and after. So he's 62 years old, Caucasian male, diagnosed elsewhere with Gleason 4+3 prostate cancer. And this was in 2018. Okay, so 2-3 years before I treated him. His bone scan was negative. And I'm sure every country has these patients who refuse to have any of the standard treatments. And he decided he wasn't going to have anything done. And he went and became a hermit down in Mexico. And he lived on almonds and almond extracts and so on. Unfortunately, his weight went down, but his PSA went up. So he became a bit healthier, but his PSA continued to rise, as you'd expect with a Gleason 4+3 relatively high intermediate grade prostate cancer. His PSA had gone up to 6.8 when he came to see me in January 2020. He had normal erectile function, and of great importance was that his partner was 30 years younger than him and obviously very sexually active, and he was keen to preserve that function. So we discuss all of our patients on what's called an MDT, multidisciplinary team meeting. We review the MRIs, we review the biopsies that are available to us, and we discuss all the options that are available to the man. So active surveillance, I put a question mark. He already had some active surveillance and his PSA was progressing. His MRI also showed progression. One option was a radical prostatectomy, but radical prostatectomy carries anything between a 50 and 67% risk of impotence to remove the whole prostate, that is. So very high incidence of erectile dysfunction and much higher risk of incontinence. We quote a figure of about 10% at 1 year, but in fact, it's likely to be a lot higher than that. External beam radiotherapy was also an option, often accompanied by hormones, which would make him impotent in any case. Brachytherapy is a form of radiation. He could have had cryotherapy. He could have had a form of focal therapy. And I've listed all the varieties that are there for him. He chose focal HIFU on the basis that it was likely to have less harm. And these are the options of focal HIFU. We could treat a quarter of the gland, we could treat the whole right side, or we could just do a very tight fusion HIFU exactly where the tumor is. I think he opted to have the right side treated. And these are just some screenshots of the machine and the display that we get. We plan the treatment. We use MR fusion. So we bring in this MRI and fuse it real time with the ultrasound like we would for a biopsy. We then draw a margin around that And you can see that red dotted line, and we would treat that area within the prostate. So to ensure that we treat any cancer cells slightly outside of the tumor as well. So you can see the accuracy of the treatment as it's occurring. The red dots are showing you the treatment as it's continuing live. It moves robotically through the patient, through the aspects of the prostate, which we plan as we go along. So there's a lot of operator work that goes on in terms of planning this treatment. And you can see there, the right-hand side has been treated where his tumor was. And I think I've got some data. Yeah, so this is what we did afterwards. So he'd had his MRI, he'd had his biopsies, we'd had a discussion about him and reviewed everything. Then he had chosen HIFU. He was treated as a day case under general anesthetic. So he went home the same day. He takes antibiotics for 5 days. He does have a urinary catheter in to drain the bladder, and he goes home with that for 5 days. And that is the bit that most men don't like, but it's a necessary evil because the prostate gland swells as you treat it. And as a result of that, he may not be able to pee if we were to take it out otherwise. But if we took his out at 5 days, he managed to pass urine satisfactorily. Some places do an early MRI. We tend not to do that nowadays. We do one at 1 year. And I review him at 4 weeks, which can be by telephone or by Zoom. And then he has his first PSA check at 3 months. And that continues at 3 monthly for the first year. And you can see this guy's readings, really low PSAs. And in the second year, it goes up to 6 monthly, and the third year, once a year. And that can all be done locally wherever they reside. He does have an MRI at 1 year. The reason why we do that is to ensure that the area we have treated has gone and that nothing new has developed in the interim. And if his PSA stays low, he won't need any more MRI scans. He would have been cured of that particular prostate cancer. The chap that I'm talking about this is not quite a self-portrait. He doesn't quite look like that, but he drew this when he was agonizing over his decision as to whether to have radical treatment or not. He had prostate cancer. His young muse was standing in front of him, trying to take his mind off things. And he sent a picture of this to me, and he said, look, this was how I was, and now I'm much happier. So in conclusion, the new targeted biopsy inevitably requires us to match our treatment to the biology of the disease. Focal therapy preserves tissue in order to preserve function, and this happens in many other cancers. Prostate cancer was out on its own from that point of view. For example, breast cancer. 25 years ago, if a woman had breast cancer, she would have a mastectomy. No ifs, no buts about it. Nowadays, it's pretty rare to have a mastectomy. She would have the lump removed, and she would have the rest of the organ treated with radiation or something like that, and she would preserve the organ. Similarly, lung cancer, similarly, kidney cancer, similarly, thyroid cancer. We don't go around removing the whole gland anymore, the whole organ. We tend to preserve function by retaining as much as we can. We know that focal therapy has shown a low side effect profile, and it provides good medium-term cancer control. Long-term data, by that I mean greater than 10 years, are awaited, and we're more or less there. But men should be told about all of their available options. So that's it. Happy to take any questions.
Thank you very much, Mr. Nigam, for that fantastic presentation. That was brilliant, and I'm sure that everyone got something from it. In terms of the questions, so we have had some pre-submitted questions. I think that you covered a lot of them in your presentation, but there is one very simple one, which I think is a good one. It simply says, how is the HIFU treatment actually carried out? Now, you covered some of that in the presentation,
sure.
But in terms of what happens physically?
Yeah, absolutely. No, that's important to know. So, so basically, it's done firstly under a general anesthetic, so the patient doesn't feel anything, and we use a probe, an ultrasound probe, which also has a treatment modality on it. It's what we call a biplanar probe, and that is delivered through the rectum. So the ultrasound beam is focused highly through a concave plane directly into the prostate, which lies right next to the rectum. So essentially, I always liken it to, and some people may have done this, if you shine the sun's rays with a magnifying glass onto a leaf, the leaf will burn, but only if you focus the sunbeam directly onto the leaf. If you put your hand in the middle, it won't burn. And this uses a similar principle whereby the high intensity ultrasound energy is focused directly into the prostate. It doesn't burn a hole in the rectum. I wouldn't have a job after 17 years of treating if I was burning holes in the rectum. So essentially, it's a very safe way of delivering the ultrasound energy. So there are no cuts involved, nothing like that. And the energy is treated directly into the prostate. And then it's planned at real time with the tumor on the screen, etc. So I know exactly the area that I have treated. And then once you've treated, they have a catheter put in, they wake up, they have a drink, they eat, and so on, and they go home with the catheter the same day.
Okay, excellent. And can I just say, if anyone has got additional questions, please do put them in the Q&A. And as I said before, if we don't have time to answer them, we will answer them by email for you. You covered the bit about the difference between HIFU and other prostate cancer treatments, which was really helpful. Another question, can HIFU be done without recurrence? I think you touched on the recurrence element.
Sure. So our data show in the short term excellent results, but even in the long term, we showed that 18%, and we normally quote a figure of about 15%, may need another treatment at 5 years. Now, that does not mean that the same cancer that we treated has come back, because you can have what we call out of field recurrence, which basically means that you've treated a particular area, but then a new cancer has developed, say, on the other side of the gland. Okay, and the incidence of a repeat treatment was about 18%, but only about 6 or 7% actually needed a full whole gland treatment, such as radiation or radical prostatectomy. Now, it's very important, and I didn't mention this at the time, but a lot of people think that if you've had your prostate cut out completely, i.e. a radical prostatectomy, that's it, you're done. Prostate's gone, it will never come back. If that was the case, we would not be having this discussion today, because we would say to a man, look, this is your only chance of cure, 100% will be cured, and you just go and have your prostate taken out. But that is not the case, because there's something known as a positive margin. A positive margin means that the whole prostate has been removed. The pathologist examines the specimen, gets to the edge of the prostate, and he or she can see some cancer cells at the edge. So what he or she does not know is that are there microscopic cells outside of that margin? And that is known as a positive margin. And people are surprised to learn that even in very good surgical hands, the incidence of that is between 15 and 17%, which means that basically 1 in 6, 1 in 7 men who have a radical prostatectomy will not be cured of their prostate cancer. So it's with that backdrop that lesser treatments, less invasive treatments have been devised. So it's important to know that a radical prostatectomy is not always the final answer.
Okay, thank you. I think this is also an important one. What are the side effects of HIFU treatment?
Yeah, so again, I touched on those. So the incidence of incontinence is between 1 and 2% at 5 years, which is extremely low. The incidence of impotence, i.e. losing your erections, we quote a figure about 15% at 5 years, which again is highly favorable compared to radiation or radical surgery. So
Okay.
those are the sort of side effects. Obviously, a slight risk of urine infection, but we cover that with antibiotics. The prostate gland does swell a little bit, so some people have some urinary issues immediately afterwards. Partly depends on how big their prostate is to begin with, but the vast majority can be dealt with, and most patients do extremely well with it. But they have to be highly selected on the basis of their MRI and their biopsies.
Okay, brilliant. Thank you. There were a couple of questions that came in during the programme that I think a number of people would want the answers to. So I'm just going to shift to those.
Sure.
The first one, what can cause a patient who's had HIFU treatment to end up having a radical prostatectomy? I know you touched on that, Mr. Nigam, but just to make it crystal clear.
Sure. Yeah, so it is obviously due to recurrence or the development of a new tumor. Like I said, in our longer term study, it was about 6.6% that needed either radical surgery or radiation. And that would have been due to a recurrence of the prostate cancer, or like I said, the development of a new one, because the rest of the prostate is still there. So that's why we use our precision diagnostics to make sure that we're not missing any other cancer at that time.
Yes. Okay.
But the fact that you can retreat with the same modality makes men a lot happier, because they think, okay, I might be 75 now, but I'm very, very active. If I can have 5 years, 6 years, and then I can have it zapped again. So we almost then begin in that sort of elderly population, begin to treat it like a chronic disease, that you can just keep on top of it and keep it at bay so that it doesn't spread or kill the individual.
Yes, absolutely. Thank you for that. I think this is the big question coming up, Mr. Nigam. So because a number of people have asked that question to me, and I've done a little bit of research, but let's see what the expert says. In your opening statement, you stated that there was a high incidence of prostate cancer in African and Afro-Caribbean men. Why is that?
Yes, if we knew the answer to that, we could modify it, couldn't we? No, I mean, I think there are genetic studies that have gone on which have shown certain genetic predispositions in those ethnic groups, which may lead to the development of prostate cancer. Obviously, now men from the African subcontinent are surviving longer, okay, and we know that age is a factor. We know that there isn't a sort of smoking risk or alcohol related risk or obesity risk. There is some talk that in terms of diet, and these are anthropological studies, and certainly I put some weight on them, although not everybody does. And the anthropological studies show that man did not develop prostate cancer until he started eating meat. Women did not develop breast cancer until they started having dairy. These are, like I said, from anthropological studies. So there does appear to be, it's a question that I get asked all the time, what can I do to modify my risk or reduce my risk? And, it's general advice, basically. Don't have too much meat, don't have too much dietary fat, don't have too much dairy, and try and have more vegetables and so on. Specifics within diet have been studied, like selenium and so on, which is found in vegetables and so on, but the jury is still out as to whether it actually makes a difference or not. So a lot of men and their wives and their partners want to know what can be done to modify risk. And sadly, the short answer to that is not a lot. So the answer to African American men, it's still obscure really as to why those men have higher grade disease and why there is a greater preponderance different ethnic groups have different associations with different diseases. We know that. So.
Okay, thank you. Got some very interesting, they're coming through thick and fast. So I'll pick the ones that I think that a number of people may ask. And one of them, really simple one, what causes prostate cancer?
Yeah, well, I just touched on that on my last answer. We don't really know. So we know increasing age, will lead to the development of prostate cancer. Family history will lead to the development of prostate cancer. Having intact male function in terms of testosterone levels and so on can predispose to it, because there are certainly genetically compromised individuals who do not produce any testosterone at all, and they do not appear to get prostate cancer. Interestingly, there is only one animal in the animal kingdom. No, actually, I think there are two that develops prostate cancer. One is the dog, and the other, I believe, is lions that develop prostate cancer. And the reason why dogs, they think, get it is because the dog eats at man's table. So is there a dietary link? We don't always know. But yeah, those are the only risk factors that we're aware of, as well as obviously ethnic minority risk.
Yeah, excellent. That's an interesting tale. I've got a couple of quick questions, Mr. Nigam. You talked about the quality of scans from Africa. I'm aware that that there are people on from the USA, Canada, and a few from the Caribbean. So I don't know whether you've had you've treated people who have come over from the Caribbean, and just wondering what the quality of those scans are like in comparison.
I have treated people from the Caribbean, but they did not usually have all their scans done there. So we ended up repeating them in the UK. We have a setup whereby we can do MRI and biopsies very quickly. So literally patients need to arrive for 2 days. They have the MRI on the first day, and we usually get the result and the report back that same evening, and then we can do their biopsies the next day. So we do offer that service, which is fairly rapid, for people, to see whether they're suitable, for it. So I can't comment too much about the quality of the scans from the Caribbean.
Okay. Another question, quite an interesting one. Which of these, A, B, or C, has the least risk of incontinence? We've got HIFU, cryotherapy, or nanoknife, which carries the least risk?
Yeah, that's a very interesting question, because we are very, very careful in choosing the modality that is likely to cause the least harm for that particular location of cancer. Cryotherapy is used to treat in what we call the anterior, or the top part of the prostate, which is furthest away from the rectum, because cryotherapy is a little bit more destructive than HIFU. So we tend to preserve HIFU where it lies closest to the rectum, in the posterior part of the prostate, and use cryotherapy for the top part, or the anterior part of the gland. Therefore, the risk of incontinence with both should be very, very low. With cryotherapy, it's also about 1 to 2%, as it is with HIFU. With nanoknife, we don't really know, but again, we're being very cautious about treating only the anterior part of the prostate. So if you select your modality correctly, then the risk should be no greater than the other.
Sure. Okay, excellent. I'm conscious of the time, and I know that a couple of people have asked about the cost of HIFU treatment. If you drop consultation in the chat, then we can talk to you about the package, because what we've developed as a partnership is a package that includes the therapy plus looking after you, so accommodation, transport, making all the arrangements for you, so that that takes the stress and burden away of doing that. So if you want to know about the cost, or you're interested in getting a virtual consultation with Mr. Nigam, please do just drop consultation in the chat and we will contact you afterwards. So I'm just going to have a quick look to see if there's if we take one more question. Someone has asked, Gary, who's on our team, has asked lots of questions. Well done, Gary. How important is vitamin D in the prevention of prostate cancer?
Yeah, another good question. Vitamin D has been proposed, or adequate vitamin D levels have been proposed in a number of different medical conditions, not just cancer, as being causative if you have low levels. So within prostate cancer, I don't know of any specific studies on vitamin D alone. But if one accepts that vitamin D plays a role in a number of bodily processes, including cancer development, then I see no reason why not having adequate levels of vitamin D would not help the man in trying to avoid the development of prostate cancer. Certainly in the treatment of it, there is no role. Okay,
all right. Thank you very much, Mr. Nigam. That was really informative, a lot of food for thought. I always find that during these presentations or discussions, the men cross their legs.
Hopefully not too bad. Yeah.
Yeah, thoroughly enjoyable. We really appreciate you taking time out of your very busy schedule to come and do this presentation. I hope everyone found it really informative. We certainly did. We have recorded the webinar, so that will be available for anyone who wants a copy of it. And I just also wanted to thank again Brian Lynch. He's not on, I don't think, but from the Focal Therapy Clinic for enabling this, and everyone that attended, and also Oyinye, who helped us with setting up the webinar, etc. And the rest of the team. We've got Gary and Sam here as well, giving the support that they did. So thank you, everyone. And once again, if there are any questions, if you've got any further questions, please do let us know and we will answer them by email. And if you wish to book a consultation with Mr. Nigam, please do get in touch. You can drop consultation in the chat, or you can email us directly and we will facilitate that for you. We've come now to the end of the webinar. So thanks, everyone. Bye-bye now.
Thank you.